see here. Again, I'm Frampton Gwinnett. I'm thrilled to be here for this Spark webinar. I see we have awesome turnout, which I'm super excited about. I'm from the Medical University of South Carolina. I'm in the Department of Child and Adolescent Psychiatry and also Adult Psychiatry. So I work with kids all the way through adulthood, and I specialize in autism. So I'm really excited to be here. I'm a proud member of the Spark team. We have a site here at the Medical University of South Carolina. I wanted to give them a quick shout out. And our leader is Dr. Laura Carpenter, who is in the back row there with the cardigan on. So just want to give them a shout. They're doing incredible work. I'm going to try, I know we're getting behind, I'm going to try to use a laser pointer here to use, it helps me point things out as we go along. So while I'm doing that, getting that set up, let me see, make sure I can see my pointer. Okay, if somebody can just put in the chat that you can see my pointer, that would be great. This helps me kind of highlight things as we go along. But the major objectives today, we're going to talk about mental health challenges for patients with autism and their families. We're going to discuss the diagnostic overshadowing as a concept that's really important and can be a barrier to getting treatment. We're going to talk about the treatments for comorbid mental health issues and also review how those challenges can change and evolve over the lifespan, because one thing we'll see is that kids with autism grow up into adults. And there's a theme here that the kids tend to be studied a lot more than the adults. So we'll talk about that as well. First of all, just a very quick review of what core autism symptoms are. Of course, many of us know they are social and communication deficits, as well as restricted or repetitive interests, behaviors, and activities. This is important because we're, in a future slide, going to talk about comorbid conditions. So these are symptoms that do not stem directly from autism. Here we go. So at the base of this tree, at the bottom of the screen, we can see autism as the root issue. So there are symptoms that are consistent with autism, that is the social communication deficits and restricted or repetitive interests, behaviors, and activities. So you'll notice if we go back here, we don't see hyperactivity in these core symptoms. We don't see aggression. We don't see insomnia, okay? So when we start talking about comorbid psychiatric conditions, I want to think about being above this red line. So below the line is core autism symptoms. Above the line are comorbid psychiatric symptoms, okay? So can someone with autism have depression? Of course. Can they have issues with sleep? Yes. Can they have issues with ADHD? Absolutely. But those are separate from autism. So these are comorbid conditions. And as we look at the field of autism, comorbidity is the rule, okay? It's more common versus not having a comorbid condition. All right, so moving forward, as we talk about comorbid conditions, I wanted to point out that it's very important that we look at medical issues first, okay? You think about psychiatry or mental health, my field, oh, that's probably located from the neck up, correct? Well, yes, in a lot of ways it is. However, the brain is the most important organ in the body and is the most connected organ in the body. It literally connects to every single organ system in the body, the skin, the skeleton, the vasculature, the nerves, the GI tract, everywhere, okay? So if someone, let's say, let's say they don't have autism and they have rheumatoid arthritis, so I'm circling the hand here, and they have soreness or swelling in their hands, but they're coming to me because they have insomnia. As I'm talking to them about their insomnia, I want to ask about medical problems and say, hey, what about the swelling in your hands? Is the pain so much that it's interfering with your sleep? Or have you started sleeping more poorly since you started steroids for your rheumatoid arthritis? So that's an example of how critical medical problems are, because if we don't talk about those first, we can miss the boat. Okay, now pivoting to autism, patients with autism have more medical conditions than those without autism. I've listed some of the big ones here. If I had a nickel for each time a patient who had severe constipation saw improvement in their behaviors after the constipation was treated, I'd have a lot of nickels. That's all I can say. So we want to think about medical issues. Is the epilepsy controlled? Is there dental pain going on? That could lead to somebody who, for instance, is nonverbal. They might not be able to express that they have a toothache, but they're hitting their head, for example. So we want to always think medically. Patients with autism are underserved from a medical standpoint. They have a shortened life expectancy, I believe, in a lot of largely due to their medical issues not being addressed in an ideal fashion, especially in comparison to an individual without autism. So always think medically first. Okay, so we are almost ready to talk about co-occurring mental health disorders, but I wanted to really hammer home the point that it's really important to have either a pediatrician or adult primary care physician who can assess the medical problems and manage those in collaboration with the psychiatrist. That medical piece involves a full medical history, medical exam, of course, and even a genetic workup. There are recommendations now to have a chromosomal microarray and a Fragile X test for all patients with autism, just as a bare minimum. And this can be helpful for informing us about the risk for co-occurring medical conditions, as well as being helpful for family planning. Okay, so hopefully we've really emphasized that before we talk about co-occurring mental health conditions, we need to always think medically first. Okay, now the concept of diagnostic overshadowing is important here. Diagnostic overshadowing means that once a person has been diagnosed with autism, a lot of times other symptoms may be dismissed as just being due to autism. So if someone has autism and there's a tendency for us as families and as providers to attribute all of their problems to the autism, and that can leave coexisting conditions undiagnosed. So diagnostic overshadowing is a big challenge. I have a graphic here next I'm going to walk us through. It's a little, there's a lot of activity here, but my point here is that on the left side of the screen, we may see some what we think of as psychiatric symptoms or comorbid mental health conditions like hyperactivity, restlessness, aggression, insomnia. Are any of those 4 core autism symptoms? No. If you think about the base of that tree, these 4 items are not listed in the criteria for autism. So something else is going on, okay? But diagnostic overshadowing is the tendency for people to say, okay, it's autism, let's just stop the hunt right there. We'll stop searching because this patient has autism. It's probably something with their autism. We want to look beyond the autism and think about, first of all, their physical health. You know, we don't want to miss the mark. What is going on with them physically? You know, could they have migraine headaches and that's causing insomnia? You know, are they having an upset stomach and that's causing them to be extremely restless? Okay, so we want to think medically first at all times, and then if medically everything's checking out, then we can start to discuss what about anxiety? Can anxiety cause restlessness or insomnia? Absolutely. What if there's a trauma going on, like God forbid the patient is being touched inappropriately? Can that cause aggression or hyperactivity or restlessness? Absolutely. So we want to always recognize that while people may present with psychiatric complaints, we don't want to chalk it up just to autism. We want to be thinking about their physical health and also psychiatric reasons why a patient with autism may be experiencing these symptoms. Okay, so hopefully we've talked now about diagnostic overshadowing and how that's a challenge. Next, we're going to start into the meat of the talk with the co-occurring psychiatric and behavioral conditions. Individuals with autism have higher rates of psychiatric conditions, okay? And these are symptoms above and beyond the core symptoms of autism. Again, beyond the tree trunk. So we're talking about up in the leaves of the tree and the branches of the tree. The rates are extremely high. So in kids, about 70% of kids with autism have a comorbid psychiatric condition. That includes adolescents. And then about 80% of adults with autism have a co-occurring psychiatric disorder. So again, this is the rule rather than the exception. In terms of finding these psychiatric conditions, it can be challenging because some individuals with autism are not able to self-report as easily as others. They may have language impairments or cognitive impairments. And therefore, it might be hard to see certain disorders like anxiety or depression. For instance, is the patient going to come up and say, hey, I'm depressed or I'm anxious, or might they express that in a different way? We talked about diagnostic overshadowing. Again, medical illnesses can factor in. The ability to communicate is a huge factor, and many others. But it's important to remember, too, that psychiatric conditions can exacerbate autism symptoms. I'll give you an example. Let's say someone has autism and they have few friends and social settings are not great for them because they feel challenged in their ability to communicate socially. What if they had anxiety on top of the autism? Is that going to make it easier or more difficult to be in social settings? Or what if they have sensory abnormalities and it makes them sensitive to loud noises and they don't like being in crowded places? Well, that's going to exacerbate their social deficits because many social settings are loud. So it is a very complex picture. Okay, so we're going to go on to the first of our comorbid conditions, probably the most famous one, which is ADHD. Nearly all of the patients I see who have autism also have ADHD. It's very high rates. There's a huge range of how many. In kids, we have a little bit better idea. It's probably upwards of 80%. In transition age youth, so between 18 and 25 or so, there's been very few studies. The one that really showed good data is about 15% prevalence. However, when you look at pure adults, there's, again, a huge range between 11 and 68%. So I would say ADHD occurs in high rates of individuals with autism across the lifespan and probably does not completely go away or dissipate in adulthood. So it still requires treatment throughout the lifespan. I wanted to also point out in DSM-5, which came out in 2013, autism and ADHD were separated and recognized as separate disorders. Before 2013, people were chalking up ADHD symptoms to just being part of autism, and that's not the case. They're distinct disorders that need to be addressed separately. Okay, ADHD, the symptoms are challenging because things like emotional impulsivity and attention can be common in people with autism, especially if they have cognitive deficits or executive functioning deficits, like they might have learning differences that could contribute. So the bottom line is we want to get a multi-informant assessment when we're trying to parse out ADHD. And that includes the teachers, the parents, the pediatricians, other providers, speech therapists, and also our examination of the individual in the clinic. There are a number of studies in kids showing that traditional ADHD treatments are more effective, are effective, but there are very few studies in adults, extremely few. Individuals with autism are exquisitely sensitive to ADHD medications. They're more likely than typically developing individuals to have irritability, insomnia, and anxiety in response to treatment with ADHD meds, which is tricky because they're already at risk for irritability, insomnia, and anxiety. So it's a complex picture, and you hear a lot of times start low and go slow. That's why. So the evidence overall for non-medication treatments of ADHD is really scarce, but there is some emerging evidence that internet-based coaching for things like executive skills, as well as physical exercise, can be beneficial. So in addition to our traditional medication treatments, there are also some non-medication treatments. I wanted to move next to irritability and aggression because this issue is one of the leading causes of presentations to the clinic. It can be aggression towards others, aggression towards self, but upwards of 65% of individuals with autism can have irritability or aggression. I also wanted to point out that irritability and aggression is poorly defined in the literature. This can range from everything from being non-compliant to being, violent. So this is a topic that still is being defined, but you can take it to the bank that there are high levels of irritability and aggression in individuals with autism. It can range across cognitive abilities and so forth. Based on a prospective study, I'm down here at the bottom, irritability and aggression do not appear to decrease in transition age youth. That's what that acronym is there. But in adulthood, aggression may taper down, as individuals age. So looking at irritability and aggressions, if we want to try to treat it, again, remember, come back to medical problems, but also we want to take out our magnifying glass and try to discover what could be going on that's driving the aggression. It's unlikely that the patient is trying to hurt someone. They might be trying to communicate something. There may be a stressor going on. During COVID, individuals with autism had much fewer home visits, and that can lead to a lot of stress and a lot of frustration. And they may not be able to understand completely why they're not able to go home and visit with their parents or see other relatives, for example. Sorry, I'm doing this from home, and there's a little bit of background noise, so please excuse me. But there are also other reinforcement stressors which may be possible. For instance, a patient may realize that when they're aggressive, they get sent home early from school. And if that continues to occur, that may reinforce the aggression. So oftentimes looking at the behavioral plan can be very informative in terms of heading off the irritability at the source. Also, co-occurring psychiatric disorders can also be a factor. For example, insomnia, when poorly controlled, can definitely increase irritability and aggression. And again, with the medical problems, can't say this enough, things like headaches, dental pain, constipation, even something as simple as the common cold, or musculoskeletal pain like bruised ribs, or these can all lead to irritability and aggression. Behavioral therapy can be effective. I'm sure many of the individuals in autism are familiar with applied behavioral analysis. This is one of the foundational behavioral therapies, trying to identify the function of the behavior as well as reinforcing more appropriate behaviors. And this involves intense practice, and hence why behavioral therapy is so extensive and expensive, and sometimes it can be hard to find a provider for those reasons. When behavioral therapies alone don't work, we look to our medication, and in children ages 6 to 17, risperidone and aripiprazole are FDA approved. Studies have not been done on adults with autism, so we are forced to extrapolate child data and hope that something that's FDA approved in children will also be effective in adults. Similarly, other medications, could be mood stabilizers or ADHD medications or supplements even, can also be considered for the treatment of irritability and aggression because there seems to be modest to moderate evidence. So again, risperidone and aripiprazole, those are FDA approved, have good evidence, and this middle row here, not as strong evidence. And again, especially in adults, when physicians don't have that real solid evidence, we have to proceed cautiously and really discuss in detail with the family what the risks and benefits are of medication. There's no hurry here, to medicate before we have looked at all options. Anxiety disorders, this is a huge factor for so many patients, especially adults, but also children. You'll see specific phobia, which is fear of one type of thing, like it might be afraid of heights or afraid of needles. Generalized anxiety, which is more of a pervasive type of worrying, but can also affect sleep, as well as muscle tension and headaches. Sorry, I've got a duplicate there, but these are the most common lifetime disorders. I think I meant to put social anxiety disorder. So you'll see these quite often. In anxiety disorders, many times patients with autism are not necessarily able to communicate things. They might not say, hey, I'm worried, or I'm nervous in social situations. We'll have to observe them and try to understand what could be contributing. So if they're not able to self-report, that can be challenging. So we need to dig deeper and look harder as to why they seem to be, showing a behavioral change. Like they might be irritable, aggressive, or fearful, and we're not sure what's going on. The irritability and aggression, again, could trace back to anxiety. So we need to really always have our magnifying glasses out and examining what could be the trigger or the underlying cause for these disorders. There are overlapping symptoms between something like social anxiety and autism. We talked about this earlier, where social communication deficits may be present, and that may be exacerbated by straight up anxiety in social situations, which is very common in people without autism. So there's this overlap, which is quite common. I wanted to pivot to a case vignette now and talk about a case of a young man named Peter, and this is just an educational case, it's not a real person. But Peter graduated from high school. Within a year, he got a job at a major car manufacturing plant. And this was a really great thing for him initially because he was getting self-esteem from his job. He had an identity as a worker at this company. He was getting paid. He was able to get a driver's license and a car. So he was able to achieve independence to a large degree. And at one point, however, on the assembly line, there was a modification made to his station. And that change presented challenges for him to adapt. And he was really reluctant to reach out to a supervisor at the beginning of his struggles to express, hey, I don't do great with change. I'm starting to get anxious. And the anxiety really snowballed on him. And he started to, his performance dropped because he was so worried about the timing and the pressure, and he didn't want to have everyone fall behind because of him. And it had a snowball effect, and he got overwhelmed and ended up leaving his job and hasn't really worked a steady job since then. So you can see how, in that case, the anxiety and the autism kind of combined to cause an outcome that wasn't optimal. Looking back, if Peter was able to access things like cognitive behavioral therapy, which can be helpful for anxiety, that could head off some of the anticipation. Hey, this is going to be a challenge. This is going to be a tough day. I could fall behind. If I fall behind, I could get a panic attack and I could get fired. So these types of thoughts were running through his head. And evidence-based anxiety therapy could have been really helpful. Also, mindfulness-based interventions can be useful to increase one's insight, to focus on the awareness of emotions and how our bodies will tell us when we're anxious. Things like difficulty breathing or feeling hot, feeling shaky, those can clue us in early that we're facing anxiety. Okay, there are few medication trials for anxiety in patients with ASD. So what we're really forced to do is look at kids who have been studied for the treatment of anxiety who don't have autism, or look at adults who don't have autism. And so we have to extrapolate data and use drugs that are evidence-based in other populations and hope that they work. The treatment of anxiety disorders with traditional anxiety medications has been mixed at best, according to the literature. You'll hear some studies that say, hey, this was helpful, some that was not helpful. I think one really important factor with a medication group called SSRIs, which are antidepressants, is that behavior activation can occur much more commonly in patients with autism. So antidepressants are mood destabilizers that are designed to lift people's mood upwards and take anxiety down, but patients with autism can be more sensitive and be more irritable in response to antidepressants. So not only is the evidence for benefit mixed, but also the risk side effects is higher. I wanted to pivot now to major depressive disorders, and this is a real thing in the population of patients with autism. Individuals with autism are 4 times more likely to have major depressive disorder in their lifetime compared to those who do not have autism. In adults, the rates are extremely high. Again, the studies are so few that we don't have a good range. So it's between 25% and 70%. That's a huge range. And we know that it's more commonly associated with suicidal ideation and attempts in patients with autism. So depression has a more pernicious course in individuals with autism. The rates of suicidal ideation are up to 9 times higher. So this is a major, major safety issue. And again, one of the major prognostic factors is loneliness, lack of social support. So if you're isolated, lonely, these are risk factors for depression and suicidal ideation. So in patients that I see every day, we encourage them to engage in activities such as clubs or sports or scouts or church or what have you, to not only for the sake of that activity, but also to combat loneliness, to use those activities as a source of friend and social support, because in the long run, these activities, if they result in quality friendships, in real life friendships, they can decrease major depressive disorder and suicidal ideation indirectly. Group cognitive behavioral therapy can also be helpful. Social skills training and vocational training can additionally be helpful for treating depressive symptoms in young adults. So the key here is being around other people, making friends, doing activities that are social activities is really good medicine, and it combats major depressive disorder. Also, I was fortunate enough to be a leader of a team here at my institution, Medical University of South Carolina, where we studied brain stimulation or transcranial magnetic stimulation, which is a magnet, not shock therapy, but magnetic therapy. We found that TMS is feasible and well tolerated in depressed adults with autism. So we took an FDA-approved protocol for adults with depression who don't have autism. We applied it to adults with depression who do have autism, and we found encouraging results. This is a preliminary pilot trial, but I wanted to also highlight that one of the reasons that we're looking at treatments that are not medication-based is because medications are not as well tolerated in this patient group. Bipolar disorder, I won't spend a ton of time here, but the prevalence rate is higher for for patients with autism versus those who don't have autism. Controlled trials for patients with both bipolar and autism are, I don't want to say none, but next to none. This is a tremendously understudied group. And unfortunately, since it's understudied, we have to try medications that are evidence-based in other populations and bring them to the world of autism and really hope that they work and try to minimize side effects the best we can. And again, for depressed individuals with autism, there's a high risk of activation or manic symptoms because antidepressants take people up. So we have to be extremely cautious. Now, somebody has mood swings. I think a lot of times people say, oh, well, that's just the autism. We have to remember it could be just the autism, but what about bipolar disorder? And we always want to think, is diagnostic overshadowing occurring here? So are these mood swings, just irritability for some other trigger, or do we follow the evidence and say, you know what, a real good chance that this could be bipolar disorder, and we need to take it seriously, and we need to do more studies. Schizophrenia is also more common, about 3 to 4% of patients with autism. So this means patients who might have chronic psychosis and autism. So psychosis could be missed because people may say, oh, well, they have autism and they just keep to themselves anyway, and they kind of mumble to themselves all day. So that's probably just their autism. It could be, it could not. They could be hearing hallucinations, and they could have disorganized speech based on schizophrenia, not just autism. Okay, getting towards the end of our talk here, I wanted to talk about sleep disorders. Also, wanted to emphasize, in adults with autism, sleep problems are the #1 most important predictor of quality of life. So let's step outside the world of autism for a second. Think about yourself. If you shave an hour of sleep off one night, we don't feel too good. If we did that 2 or 3 or 4 nights in a row, our health starts to deteriorate. Our concentration starts to deteriorate. Our happiness starts to decrease. The same is true with adults with autism. Sleep problems are the #1 most important predictor of quality of life. That said, up to 80% of adults with autism have sleep problems. That can have a cascading effect on autism, like social communication deficits can be worse if they're sleeping poorly. Makes sense, right? The same is true in children. Sleep problems are rampant. Behavioral therapy, specifically cognitive behavioral therapy, is the first-line treatment for insomnia for patients with autism. So, addressing it with medication is not a first step. And I want to caution, too, part of that is not only because behavioral therapy is more evidence-based, but also because we don't have studies, good studies, on treatment for many agents in kids with autism and especially adults. We do know that melatonin can be combined with behavioral therapy or used alone, and it's well tolerated. It's few side effects, and it can be effective. So the data for melatonin is very robust. So we can use that. I particularly prescribe it lower than I used to and a little earlier than I used to. So we might have had patients who are on 5 or 10 of melatonin at night, but 1/2 to 1 milligrams instead of at bedtime, maybe even at 6 or 6:30, can facilitate sleep better in many cases. Okay, this is the last comorbid condition we're going to talk about, autism and gender dysphoria or gender variance. Some emerging data has been published in recent years. I wanted to go back to 2010 and just show that in individuals, when you look at a gender dysphoria clinic or a transgender clinic, they find that rates of autism traits are higher in that group versus the general population. So about 8% of individuals who are at a transgender clinic have significant autism symptoms. And if you look at autistic traits, let me go back. I might have said that the wrong way. I'll just say this, that if you look at a group of patients with autism and look for transgender symptoms, you'll see higher rates of transgender symptoms versus the general population. And if you look at a group of people with transgender and you look for autism symptoms, you'll see much higher rates than the general population. So there's a significant overlap between autism and gender dysphoria or gender variance. We're not sure exactly how the relationship is, but in my personal experience, I've now seen probably 12 to 15 patients with autism who have disclosed that they're transgender, in my whole practice. So, I'm seeing it more and more. I think everybody is more aware now, but the data in the literature is backing this up. So it's not just a phenomenon, it's a real thing. So I wanted to first take a look back at where we've been. We've talked about autism and the root symptoms of autism. And then also we ended here with gender variance, but also a host of others. We didn't have time to mention all of them. I will mention that substance abuse is also higher in individuals with autism. But we want to remember that these are distinct disorders. They are not just related to autism. We don't want diagnostic overshadowing to occur. We want to recognize these conditions as distinct disorders with their own treatments. They need to be researched not only in the general population, which they're doing a great job of now, but also we need to research these conditions in patients with autism because, as you know, if you've met one patient with autism, you've met one patient with autism. So we need larger studies, controlled trials to figure out new treatments. And I think that really is a great way to end because SPARK is the largest autism study ever. And although it's a genetic study, I believe will lead to a large number of discoveries in who's at risk for the conditions you see up here and who are good candidates for treatments that we discover in the future based on their genetics. So that's exciting. So I feel hopeful about that. And then finally, I've been blessed in my career to work with kids who grow up to be adults and that challenges evolve. And I think that's a reflection of this increase in prevalence. I'm sorry, this is blurry, but this is a slide adapted from Autism Speaks. 17 years ago, 1 in 166 children 8 years old in the United States had autism. Now it's triple that. It's 1 in 54. So we are seeing a surge, and that surge of children with autism is resulting in a surge in adults with autism. So each year, 60,000 children with autism become adults. So this is a wave. This, I believe, is the next challenge. And although it's pretty daunting to think about 60,000 18-year-olds becoming adults each year who have autism, I'm trying to embrace that challenge with one of our projects here at MUSC called the Autism News Network, where we are working every day alongside adults with autism who have anxiety, depression, ADHD, and we're using the Autism News Network as a clinical intervention, social skills training, and also job training so that they can make videos to tell their story of what it's like to live with autism, what it's like to, they're interviewing people out in the community They're interviewing local teams, learning how to make movies, learning how to tell their story about how they overcame bullying or anxiety. Talking about, they're learning how to make a website. They're putting first-person testimonials up on the site. They're interviewing guests who have autism, people like Carrie Magro and so forth. So that's something I'm really into. I just wanted you to be aware that as these kids grow up, they are so capable of amazing things. And, definitely they're out there conquering challenges, not only based on autism, but also based on comorbid mental health conditions. So, if you want to check out the Autism News Network, it's the autismnewsnetwork.com, and there's a lot of great stuff up there. And we hope that you enjoy the content and help us continue to help patients with autism achieve everything that they want to. With that, I do have a lot of references. These slides will be posted in PDF format. There's probably too many here to address them all in our talk, but they are there. And I really appreciate everybody's attention today.